I previously was from the University of Vermont, but I'm now in the University of North Carolina.
It's the expansion of New England's southern.
Right.
In the south.
But I'm honored to be here, and I'd like to thank Evelyn Lauder, Peg, Cliff, and my friend Larry Norton for all their support over the years, not only for personal research, but for all the support of the Cancer and Leukemia Group B, which is a National Cancer Institute-supported cooperative group that does many of the large clinical trials that takes advantage of our knowledge to see can we bring it to patients and how effective are our treatments, and also to my colleagues at UNC Chapel Hill, my new colleagues who have had great BCRF support over the years. So my interest is a little bit different. I'm interested in cancer in older patients, breast cancer specifically. And someone might ask, why is that of interest? Well, if you look at the data, and if you look at the diversity in the room, and you look at advertisements, we think of breast cancer usually affecting people who are 40 and 50 years old. But if you actually look at the demographics, the average age of breast cancer in the United States is now about 63 or 64. And cancer is really a disease of aging. So colon cancer, the average age is 67. And lymphomas are getting to be more common. And in spite of our clinical trials, we have found that older people frequently weren't entered in these trials years ago. In fact, I'm old enough that in many of the older trials, there were age exclusions. You couldn't go into the trial if you were 65 or 70. So we have a shortage of knowledge on, are our treatments that have worked so well and we're expanding on and learning about as effective in older people as younger people? And more importantly, as we get people, and someone 65 today isn't an older person, as we get people 75 and they come in with a high-risk breast cancer. They're not old either. I'm not going to touch that one. So, can we treat those women as aggressively as younger women? And if so, can we select up front women who might have more side effects from therapy or might not do as well? So a lot of my research now is focusing on ways of predicting outcomes of patients, and through the CLGB with funding from the BCRF, we've just done a very large study. Many of the people in the room are involved, such as Cliff and others, in looking at chemotherapy specifically given for women 65 and older with early-stage breast cancer, to look at tolerability, quality of life, and a lot of other things. So my view is a little bit different, but I think as all the fortunate things in the United States, we live longer, we're doing better, we're unfortunately going to see more cases of breast cancer and more problems. And we need to learn how to take care of those patients and to apply our best science to their care.
It's great. High is very modest. It's the largest trial ever done in the whole world in women over age 65, and it was a major presentation at ASCO last year.